We will be discussing the basics of ureteroscopy with laser lithotripsy for the treatment of ureteral and renal stones. Our patient in this case is a 30-year-old female with a history of cerebral palsy, recurrent UTIs, neurogenic bladder managed with clean intermittent catheterization, who presents with a 1.3 centimeter stone in the right renal pelvis. A preoperative CT abdomen and pelvis revealed a 13 millimeter renal pelvis stone and additional small upper pole fragments, as you can see in the axial and coronal images. The general steps of our case involve first a diagnostic cystoscopy, then getting up the ureter, next ureteroscopy and pyeloscopy, laser lithotripsy, stone basketing to remove remaining pieces, examining the ureter on the way out, and lastly ureteral stent placement. Here is a general representation of the back table setup for a case such as ours, involving a flexible ureteroscope, a rigid cystoscope, an open-ended 5 French catheter, a dual lumen catheter, various wires, and also various other tools to make our system work. We positioned the patient in the dorsal lithotomy position with care taken to preserve the pressure points such as the ulnar nerve, the perineal nerve, and the heel with foam positioners. To begin the case, first we evaluate the bladder with the diagnostic cystoscopy, as well as gain access into the ureter with a guide wire. You can see here we advance the ureteral catheter into the cystoscope and pass the guide wire through the ureteral catheter. Once we've identified the ureteral orifice, as shown here, we can advance the guide wire into the ureteral orifice. The positioning of the proximal end of the guide wire can be confirmed using fluoroscopic guidance. The wire is advanced all the way to the renal pelvis, and the ureteral catheter can be advanced a few centimeters into the ureteral orifice for dilation purposes as well as for retrograde pyelogram. In this scenario, with the initial wire in place in the renal pelvis, a dual lumen ureteral catheter can be advanced over that wire to get into the renal pelvis as well. This dual lumen catheter can be used to perform a retrograde pyelogram, and additionally, a second wire can be advanced into the collecting system. This allows for both a safety wire and a working wire. Given the size of this patient's stone, we opted to use a ureteral access sheath for access into our collecting system. Here we see the ureteral access sheath being advanced over our working wire into the patient's collecting system. This allows us to pass our flexible ureteroscope through the access sheath for quicker and easier access. Here we see our flexible ureteroscope being advanced through our access sheath into the renal pelvis. First, we take a look around at the various calyces, and we identify our stones. We take a look around and do a thorough pyeloscopy in order to identify any other findings that might warrant intervention. You can also notice our safety wire in place that can be used in case of an emergency. Once the stones are identified, laser lithotripsy is begun. You can see here that we extend the laser through the scope past the lens in order to prevent damage to the scope. And you can see that we use the laser to work on the stones. This stone is quite soft and is breaking up nicely. You can see that we're working on the leading edges of the stones with the laser as well. At a later point of the operation, once the stones are broken up into small pieces, these pieces can be evacuated using a stone basket. Alternatively, the stone can be broken up into dust, which can pass on its own. When selecting laser settings, it's important to remember that the power of the laser is equal to the energy times the frequency of the laser. Both of these variables can be adjusted to give an equivocal power with a different effect on the stone. For our case, we used a low energy and high frequency setting that allowed us to dust the stone. Alternatively, a high energy but a low frequency setting could be used to fragment the stone, ideal for basketing. Also, a pulse width can be adjusted to reduce retropulsion of the stones, And additionally, the aiming beam can be altered to reduce glare on the stone. Once our stone has been fragmented sufficiently, a stone basket can be passed through the ureteroscope in order to obtain some pieces of stone. Here we employ a tipless basket to grab pieces of stone, which are subsequently externalized through the access sheath. Once we're satisfied with the amount of stone removed from the renal pelvis and various calyces, we can examine the ureter on the way out using Pullout ureteroscopy, where we keep the scope at the proximal end of the access sheath and remove both together. You can see in this case that the ureter is wide open, and we are examining the ureter circumferentially for any signs of trauma. You can see that we encounter some more stone that might have passed alongside our sheath, which we subsequently treated. You can notice coming out alongside the safety wire. Once the ureter has been observed on the way out, stent placement can be considered as a possibility. Stent placement is particularly useful in the case of residual stone fragments in a tight ureter. Additionally, stent placement can prevent ureteral obstruction from ureteral spasm. In the case of any ureteral trauma that is observed, a stent is useful in reducing stricture rates in the future. The length of a stent can be decided based on two methods. The first is to measure the distance between the renal pelvis and the pubic tubercle on a CT image. Additionally, this formula can be employed where a patient's height in inches minus 42 can be considered to be the length of the stent employed. Once a stent size has been selected, the stent can then be advanced over the safety wire into the patient's collecting system. This can be done under direct vision or under fluoroscopic guidance. It's important to verify the positioning of the stent with the proximal curl in the renal pelvis as well as a distal curl in the bladder. The distal curl can also be observed using rigid cystoscopy at the end of the case. Postoperatively, this patient was discharged the same day a few hours later with the right ureteral stent in place, with the plan to remove the stent in the office in 1 to 2 weeks. Given this patient's history of recurrent UTIs, the patient was continued on a course of antibiotics as well. In summary, ureteroscopy with laser lithotripsy is a common tool in the urologist's arsenal that allows for the minimally invasive management of kidney stones.